answered questions. So it makes it very exciting, and hopefully younger people in the audience will also get excited and want to dedicate their career to neuroendocrine tumors. So just as a background, it's actually fairly new that we've been diagnosing the true pancreatic neuroendocrine tumors. When we think about adenocarcinomas, we've known about them for much, much longer. Now, the neuroendocrine tumors are a small percentage of the pancreatic neoplasms, but these are the patients where the conversation about what to do becomes much trickier because we know that many of them are very slow growing and fairly indolent. And so in that background, it really becomes a really good discussion about who do we offer an operation for? Because we know one thing for sure, not everybody should get an operation just because they have a pancreatic neuroendocrine tumor. And it brings up issues that we still have yet to define, right? If we understood the biology of the neuroendocrine tumors, if we could develop a cell line of neuroendocrine tumors, we could study that much, much better. And we could give our patients much better answers, right? And so in the context of a fairly indolent tumor, the comorbidities of the patient and their life expectancy become a much larger topic of conversation. For adenocarcinoma, we're willing to operate on people with heart disease and lung disease and kidney disease in the hopes of just giving them a little bit of a longer life. And it becomes much less of a conversation of who should get an operation, but really how to do the operation. But for neuroendocrine tumors, that's a very different topic, right? And we have different options. Enucleation, like do we really need to do a formal oncologic resection? Or can we just enucleate that small tumor? Obviously, in the setting of not seeing any enlarged lymph nodes. If we see enlarged lymph nodes, I think all of us agree that you have to do more of an oncologic operation. But whether that's a distal pancreatectomy or a central pancreatectomy or a Whipple or just observation, right? And with these pancreatic operations, as everyone in this audience knows incredibly well, we would all love to say to our patients, there are no complications and there's no mortality, but that obviously is not the reality. And we know the risk of a pancreatic fistula is higher after a Whipple for a neuroendocrine tumor than for an adenocarcinoma. I just quickly bring up the issue of functional tumors and symptomatic patients. There, that discussion again goes away, right? Because we know if you have a functional hormone-secreting tumor, we need to be aggressive about getting that out for your well-being as a patient. And of course, patients who are symptomatic, and there are the small percentage who end up having a neuroendocrine tumor that's blocking the duct and gives recurrent pancreatitis, or is larger and is causing jaundice. And so that becomes a much clearer conversation. But the real debate is the asymptomatic small non-functional PNET. Right. And the definition of small is also a great conversation. And I think most of us would agree 2 centimeters or less than 2 centimeters is really the hottest debate. I think most of us would agree that under 1 centimeter, we do not need to be aggressive about resection. So it's really that 1 to 2 centimeter neuroendocrine tumor that usually is found because they have a scan for diverticulitis, for a kidney stone or whatever other reason, and it's incidentally found. And so I thought I would put up the NCCN guidelines just as a reference. But even here, there is still debate. When you look at the different options for small, less than 2 centimeters, right? Observation versus enucleation versus resection. So in many ways, these guidelines are helpful, but I don't think answer our question. And unfortunately, when you look at these guidelines also in terms of the follow-up, they also leave a very broad range, right? So you can imagine you take somebody who has a 1.5 centimeter neuroendocrine tumor, you remove it, there are no nodes positive, or you enucleate it and there are no nodes that are suspicious on the scan. And then the patient says, well, I looked at the NCCN guidelines and I want to scan every 3 months for follow-up. And we all know that is absolutely unindicated, because most likely this patient will never recur, right? Especially depending on their age. If they're in their 70s, the chance of them recurring is so low. So how do we define these tumors better and try to do a better job at classifying them? And, we go back to very historic things like H&E mitotic count. And it actually turns out that it's actually not that easy for pathologists to even agree. And even with Ki-67, there is discrepancy. And ideally, you would count up to 500 cells to be able to give an accurate Ki-67. Now, I don't know about your pathologist, but I bet they're as busy as our pathologists, and they don't have time to be counting 500 cells to give us an accurate Ki-67. But these things are essential to the classification of these tumors, right? And so clearly we have a long way to go in terms of how do we better classify them so that we can be more accurate. And if we are more accurate, can we do a better job of defining who needs an operation and who doesn't need an operation? Now, the other part of this, this is, NCDB data, which, of course, all these large databases have constraints. But you can see at that sort of 1.5 to 2 centimeters, about 30% have positive lymph nodes. So that becomes a little bit more concerning. And how good are we at defining positive lymph nodes preoperatively on the scan? Now, we of course always hope that a serum marker can help us, and I think chromogranin A is obviously very, very helpful, but in many ways it's something that ends up being relative, right? So we know if it goes up in the patient, that is more helpful than the absolute value that they have. Now, biopsying, right? Many of us say, to try to buy some time, say, okay, well, let's biopsy the neuroendocrine tumor with an EUS and FNA. But when you look at it, only about 60 to 80% correlate with that surgical specimen. And that doesn't mean that the surgical specimen is always a higher grade, sometimes a lower grade. But the point is that these FNAs or even the microcores can only be so accurate. And so we look to some of the imaging features that might be helpful. So more than 2 centimeters, pancreatic ductal dilation, vascular involvement, lymphadenopathy, and this texture parameter entropy is being worked on as a form of radiomics to see if we can further delineate this. Now, we can always go to the more expensive tests, right? And we can go to the tests that are an Octria scan, a dotatate PET, right? Many patients come into the office now saying, I want a dotatate PET, and they have a 1 centimeter neuroendocrine tumor. I don't know how expensive it is, where you practice, but for us, it's very expensive. And the insurance companies gave us a lot of pushback about getting these scans, right? But they are more sensitive and can be helpful in trying to determine extent of disease and maybe the aggressiveness. There's no question. There's some FDG PET data that indicates that with higher SUVs that you have a more metabolically active and therefore more aggressive tumor. And so what we tried to do in a manuscript that we published a few years ago is say, let's look at a very granular level at the neuroendocrine tumors who were not operated on and followed, and let's look at the ones who were surgically resected and what their outcomes are. So the downside of this series is it comes from a single institution, right? The upside is that you have very granular data and you can go back to look at the charts of the patient, and the pathologist can re-review slides as necessary, especially with some of the older samples where the classifications were a little bit different. And what we found was, yes, the patients who underwent a surgical resection had an overall survival advantage. But I would caution, right, because this was the whole cohort, right? And so then we really need to be more granular about this, right? Because, yes, the people who had an operation, some of them had bigger tumors, some of them had lymph node positive disease. And here you can see with a subgroup analysis of the less than 2.5 centimeters, which I think is more relevant. It does demonstrate that we still rely on tumor size. And it seems so crude, right? We've made so many great strides, but yet for neuroendocrine tumors, we always fall back on size. And when we looked at the different size cutoffs, we found that the advantage was statistically significant over 1.5 centimeters. But I will tell you that in practice, we still continue to push it closer to 2 centimeters, because you can also look at these patients who we observed. And I put the 3 larger series of patients who were observed, and you can see how long they were observed for, right? So if you need a Whipple for a 1.8 centimeter neuroendocrine tumor, if it were me, I'd rather you do it in 5 years than you do it today, right? As long as we think that it's still safe. So, you know, the management algorithm has so much work to be done, right? And this is why it makes it exciting. I put up this up-to-date algorithm, which I think is a very nice basic outline, but it is so broad, and it just is to emphasize how much work we still have to do. And so we need, you know, as many people as possible to really think about this, so that for all those less than 2 centimeter neuroendocrine tumors that are non-functional and asymptomatic, that we can do a better job of choosing who to operate on. So what I would say in summary is that they tend to be slow, indolent tumors. Surveillance is safe for many patients. And when we think about who to resect, it's symptomatic patients. I would say a size at a minimum greater than 1.5 centimeters. High-grade features, whether that's imaging, pathologic, molecular. And then, of course, taking into account the patient's comorbidities, the operative risk, and what their true life expectancy is. So, in conclusion, I would say that for these tumors, you really need to base it on so many more factors, and there's so many more unknowns as you try to counsel your patients. And I would say minimum 1.5 centimeters. So as always, we don't ever want to harm patients by being too aggressive. But a special thanks to all my surgical colleagues at MGH who helped to put all of this together. And I'm very happy to take questions, and I have 2 very short cases if it's at all helpful for anyone. Thank you.